Good afternoon, and welcome to the Cottage Health Virtual Meet the Doctor featuring Dr. Britta Gray with the Cottage OB-GYN Clinic. I'm Christy Borneman, the Marketing Manager for Cottage Health, and I'll be your moderator for today. Before we get started, I'd like to review a few housekeeping items to optimize your viewing experience. At the conclusion of our presentation, we will host a brief question and answer session. Please use the Q&A button to ask Dr. Gray a question. This webinar is also being recorded and will be emailed in a few days. It's now my pleasure to introduce Dr. Britta Gray. Dr. Gray is a board-certified OB-GYN. Prior to joining Cottage OB-GYN Clinic, she practiced for 5 years at a federally qualified health center in East Palo Alto, California, where she had hospital privileges at Lucile Packard Children's Hospital, Stanford, and San Mateo Medical Center. Dr. Gray earned her BA in Medical Anthropology from the University of California, Berkeley, and a Master of Public Health and Doctor of Osteopathic Medicine from Nova Southeastern University in Fort Lauderdale, Florida. She completed her obstetrics and gynecology residency and served as Chief Administrative Resident at the University of Miami Miller School of Medicine, Jackson Memorial Hospital in Miami, Florida. Dr. Gray is a native Californian and is fluent in Spanish. Please join me in welcoming her.
Hello to all, and thank you so much for joining this virtual presentation. And thank you, Christy, for the kind introduction. So today it's my honor and privilege to be speaking on the importance of an annual gynecologic visit for the modern woman. The main objectives of my presentation are listed on this slide, but I also really look forward to the question and answer session that we'll have at the end to engage with all of you and also to take the discussion really in any direction that you're interested in. Before we get started with the presentation and going into all the current recommendations and guidelines, I really think it's worthwhile to briefly discuss the history of what's called the Well Woman exam, or that annual preventative gynecologic exam. Until the year 2003, most national guidelines were recommending annual pap tests, so most women were accustomed to seeing a gynecologic provider yearly for this exam. But the guidelines changed majorly in 2009 and again in 2012, and it's been for a trend for less frequent pap testing. We'll go into this in a lot more detail in the next few slides, but what we observed in the field of gynecology was that patients stopped scheduling preventative health appointments with their gynecologist when they were told they didn't need a pap test. And this is precisely the reason why I chose to title this presentation, "Why Should I See a Gynecologist? It's More Than a Pap Test." The American College of Obstetrics and Gynecology endorses a, quote, periodic preventative healthcare visit for all women. And the word periodic is intentionally left nonspecific, as the recommended interval should be individualized. Most major insurance companies will cover an annual well woman visit, and Medicare will cover a visit every 2 years. The overarching goal of this preventative health visit is to promote health. And this is done through a combination of medical history, physical exam, screening, counseling, and immunization. At an exam, you can expect a gynecologist to review a thorough medical history. And much of this history may be similar to what is reviewed by a primary doctor at a physical exam, but several components of the history might only be addressed by a gynecologic provider. So these are things such as a menstrual history and an obstetric history. For reproductive age women, we know that the menstrual cycle is a vital sign and offers tremendous insight into one's overall health. So it's worthwhile to discuss this yearly with a provider, and this can change over time as well. This visit is also an ideal time that a patient can discuss other gynecologic concerns with their provider. Some of these concerns may be able to be addressed at that visit, or they can prompt follow-up, more problem-specific visits. After taking a history, a gynecologic provider may discuss the option for a pelvic exam as part of the visit. A pelvic exam includes an inspection of the external genitalia, a speculum exam and any appropriate testing, as well as a bimanual exam. And this is the medical term for an exam that evaluates the size and shape of the uterus and ovaries through the vagina. These exams can be performed individually or they can be performed all together, or they can also be completely deferred based on a shared decision between the patient and the provider. I want to emphasize an important point that routine pelvic exams are no longer the standard of care for asymptomatic patients. This is such an important point to make because I know, as we all know, that pelvic exams are very difficult. They can be uncomfortable and they can be very anxiety producing for a lot of patients. We certainly do not want a person's apprehension about a pelvic exam to be the reason they do not see a gynecologist. We'll now move on to a discussion of pap smear, and pap smear is for cervical cancer screening. This is what I mentioned previously, that the guidelines have changed over the past 20 years, and that can be very confusing to people. I'll discuss the most up-to-date guidelines in the next few slides, but before we do that, I like to just take a few steps back and really delve into a few big questions, such as what is a pap smear, what is it for, and why is it so important? I think the context is really important here. So to keep it very simple, a pap smear is a screening test for cervical cancer. The pap test was developed in the 1920s by a doctor named Dr. George Papineau-Colau. That's how it's got its name. He also developed this test with his wife, Mary. And the test was used broadly in clinical practice starting in the 1940s. The pap test was a huge advancement for gynecology and public health. Because at the time of its discovery, cervical cancer was the most common cancer-related death among women. Dr. Papineau-Colau proved through his work that cervical cancer has predictable and precancerous stages, and that by taking a microscopic exam of a swab that's collected from the cervix, that these changes can be identified and allow for timely intervention in cancer prevention. I feel an extra special connection with Dr. Papineau-Colau because he led a research institute at the University of Miami, and I drove past it every day for 4 years while I was doing my specialty training, and it's actually there that I learned to do his pap test. So he's a cool guy in my books. The mortality rate from cervical cancer has decreased by 70% since the pap smear was introduced. However, on this slide, I like to point out data from the National Cancer Institute that shows that both the rate of new cases of cervix cancer and as well as the mortality or the death rate has not decreased significantly in the past 10 years. And so this really underscores to me the importance of new strategies for prevention and leads nicely into our discussion of the next big advancement in gynecology, which is an understanding of HPV infection and prevention. So the next huge advancement in gynecology occurred in the 80s with the scientific discovery of the human papillomavirus. So this is HPV. And it was identified that HPV was the cause of over 90% of cases of cervical cancer. In 1988, the first clinically available HPV test was released on the market, and HPV testing became a part of cervical cancer screening guidelines starting in 2003. So on this slide, I have posted the most up-to-date screening guidelines that are endorsed by our college, the American College of Obstetrics and Gynecology, and they were published in 2018 by a large US organization that makes recommendations on all different sorts of testing called the USPSTF, or the United States Preventative Services Task Force. Lots of letters there. But yeah, these are the most up-to-date guidelines. And I'll just comment on a few of the most important points here. So you may see that current guidelines recommend starting pap smears at age 21 in women. So this is regardless of the age of initiation of sex. PAPs are recommended for all women at 21. And the primary screening strategy for younger women is just pap testing without HPV testing, just a pap smear. And a very good question would be, why don't we want to test young women for HPV infection? And the very interesting answer to this is that if we were to test all young women, we would find very many positive results, and this would undoubtedly lead to overintervention. So we've gathered a lot of information about the epidemiology of HPV over the years, and studies have consistently shown that HPV is the most common sexually transmitted infection worldwide. So 8 in 10 sexually active people have seen HPV. We know that women tend to become infected earlier in their sexual life. But the good news is that over 90% of women will clear the infection within 2 years. Even low-grade abnormalities detected on Pap smear are likely to resolve on their own in young women, and therefore biopsy and treatment can be safely deferred most of the time. So in women over age 30, so women between 30 and 65 years old, the guidelines change. And here the recommendation is for HPV screening as the primary screening modality with or without a Pap test. And this can be done every 5 years. When a Pap smear is done with an HPV test together, this is called a co-test. And this is very commonly offered in our community, including this is what we offer at our Cottage OBGYN clinic. A positive HPV test can be further analyzed to detect the strain of HPV because we know that there are 2 strains, HPV strains 16 and 18, that are associated with the most cases of cervical cancer. An abnormal Pap or a positive HPV test should prompt further evaluation. And this is a very nuanced and also very challenging discussion and something outside the scope of this presentation, but that's something that could definitely be discussed in detail with a gynecologic provider. A small point that I think is really important and I wanted to address today is that I encourage patients to obtain the results of their Pap and HPV testing and never assume that, quote, I'll be contacted if something is abnormal. I think we're getting better about this in the age of electronic medical records and patient portals as people are having access to their medical records. But I still come across it almost every day in my clinical practice where somebody will tell me that they were not informed of their Pap results. And usually this is because they were normal. But I think this is still really important information for a person to keep track of. In my personal practice, what I do is I always explain to patients after I do a Pap test that they'll hear from me good or bad, because some people get nervous when I reach out with results, but it's not always bad news. Sometimes it's good news. And I want people to keep track of their results and then also understand the recommendation for the timing of their next Pap test. Going back to the slide, wanted to comment on 2 other things. So current guidelines suggest that we recommend that we discontinue Pap smears in women over 65 years old. And this is based on solid data that women who have consistent prior negative screening have a very low risk of developing cervical disease. There's also an increasing risk of false positives as kind of the cellular nature of the vagina changes as we age. We also advise against Pap tests in women who have had their uterus and cervix removed through hysterectomy. I'll now be moving on to a discussion of the HPV vaccine. This is probably one of the topics that I'm most passionate about, and as well as many others in my specialty. So, in this presentation, I really hope to educate the audience and also empower you to discuss with a gynecologist if the HPV vaccine is right for you, or maybe your partner, or maybe your children, based on the information that I provide. I would argue that the introduction of the HPV vaccine is the most exciting advancement in gynecology since the Pap smear. In 2006, the FDA approved the first HPV vaccine, and it was called Gardasil 4. It was initially approved for girls ages 9 through 26. In 2009, the FDA then expanded for the use in boys and men. And then in 2014, something else very exciting happened in that the FDA reviewed safety data and extended the approval of the vaccine through women and men up until the age of 45 years old. So current recommendations are from anyone from 9 to 45 years old. The vaccine was also expanded. It's now called Gardasil 9. So this means that it protects against 9 strains of HPV infection. So the original one was only 4 strains. In this current vaccine, Gardasil 9, it protects against 2 strains, which are called 6 and 11, and these are the strains that cause genital warts. So, genital warts are not cancerous, but they're pesky, and so it's amazing that the vaccine can prevent that. Nobody wants those. And then it also includes 7 of the high-risk HPV strains. So these are the strains that are associated with cancer of the cervix, cancer of the vulva, which is the external female genitalia, the vagina, anus, penis, as well as oropharyngeal cancers, so head and neck cancers. All can be prevented by the HPV vaccine. We have now over 20 years of data to support that the Gardasil vaccine is safe and it is extremely effective. People between the ages of 26 and 45 should discuss the Gardasil vaccine with a provider, and a well woman exam would be the perfect time to do that. And the decision to pursue vaccination in this age group should really be based on one's specific risk factors for acquiring a new HPV infection, usually through new or changing sexual partners. One really important point of clarification that I want to make is that a person can receive the HPV vaccine even if they have previously tested positive for HPV. So this is kind of a common point of confusion that I want to clarify. The rationale here is that a person is unlikely to have seen all 9 strains of HPV included in the vaccine. So even if they've seen a few of the strains or one of the strains, they'll still receive some level of protection through vaccination. There's also really interesting data to suggest that in women who have been treated for cervical precancer, the risk of recurrence is less when you've received the HPV vaccine. So this suggests that the HPV vaccine may help the immune system hide the HPV infection. It's an area of ongoing research and something I'm always excited to learn more about as more studies are published. And I think in the next few years, we'll have a lot more information on this topic. So in summary, reviewed a lot of information, but in summary, HPV vaccination is cancer prevention. So there's not a lot of other vaccines that can prevent a cancer. So this is really unique and really special. I encourage you to educate yourself, inform yourself, and reach out for more information if you're interested. We stock the HPV vaccine in our cottage OBGYN clinic, as do many other gynecology, primary care, and pediatric offices in our community. So we'll then talk a little bit about STI screening. So at a preventative exam, this is definitely something that you'll have the opportunity to discuss with your provider. And this graph or this chart will shows the most up-to-date recommendations on STI screening. You'll see here that sexually active young women, so from age of sexual onset until 25 years old, are recommended to have annual screening for gonorrhea and chlamydia, as these are the 2 most common sexually transmitted infections. They're both bacterial infections and easily treated with antibiotics. So testing for gonorrhea and chlamydia can be done through a urine test, or it can be done through a vaginal swab. In women over the age of 25, the decision to screen for sexually transmitted infections is more individualized, and it's based on risk factors. So according to public health guidelines, a person is considered to be high risk for sexually transmitted infection if they have more than one sex partner, they use condoms inconsistently, they've had a previous infection or currently are being treated for an infection, or they have other high-risk social factors such as exchanging drugs for sex or money, or a history of incarceration. These are some of those high-risk factors. And then, so they can be screened more frequently for those infections. And then we also recommend testing for what I like to call the blood STIs, or this is hepatitis, HIV, and syphilis, for all adults at least once in their life, and then more frequently as needed based on risk factors. All right, so now we'll change tunes a little bit, and I'll transition into talking a bit more about other preventative exams or topics that can be discussed with a gynecologist. So things that maybe are a little bit outside of our specialty of gynecology, but still really relevant. Uh, we know that breast cancer is the most common cancer in women, and therefore a risk assessment and screening is paramount to women's health, so it's something that definitely gynecologists are part of. Different organizations in the United States have different recommendations on breast cancer screening. And this can be really confusing for patients. It's also challenging for providers and sometimes leads to arguments or discussions with insurance companies. In our cottage practice, what we have found is that engaging with patients in a breast cancer risk assessment is really a game changer, as it allows us to choose an individualized breast cancer screening strategy guided by an understanding of a patient's unique lifetime risk of developing a cancer. And so this kind of helps us choose which set of guidelines is most appropriate for our patient. On this slide, I've listed some of the commonly used tools that are performed or that are used to perform a breast cancer risk assessment. So most of them can be found online. They involve taking a reproductive, family, medical, and cancer history. And there's no one model that's ever been proven to be better than another or recommended more than any of the others. I would say that I'm most commonly using this first one, which is the Gale model, or the last one, the Tyrer-Cuzick. The average lifetime risk of breast cancer in the United States is between 12 and 13%, so or about 1 in 8 for women. And a person is considered to be high risk if their lifetime risk is over 20%. High risk individuals are qualify for earlier breast cancer screening, and then they also can have additional types of screening, such as breast MRI. And so that's a whole topic on its own. Again, this is just there's just so many things we could go into, but that's its own lecture for sure. But I'll focus kind of my discussion today on more average risk women. So for most women, breast cancer screening is recommended starting at age 40, and the mainstay of screening is mammography or mammograms. Previously, an annual clinical breast exam was recommended, but just as with pelvic exams, the pendulum has really swung, and most professional organizations now recommend against routine breast exams for asymptomatic patients. So that does not apply to people or women who appreciate a breast lump or mass. We're just talking about asymptomatic patients. We don't necessarily need to do a breast exam. And that's because there's pretty good data to support that a breast exam does not add much diagnostic improvement as a mammogram. And there's also some pretty good evidence to support an increase in the risk of false positive, meaning a clinician palpates something in the breast that is later imaged and proven not to be worrisome or concerning for cancer. So I do not routinely do clinical breast exams in my patients, and I think a lot of providers are the same way nowadays. Nevertheless, I do feel strongly that a breast exam is a safe, it's a low risk exam, and therefore one could very reasonably talk with their gynecologist about a breast exam if that's what they feel if they would like one, if that's what they feel most comfortable with, or that's what they've gotten used to. That would be totally reasonable. So on this slide, I'm just posting the most up-to-date recommendations on mammograms for breast cancer screening. And as I referred to previously, many different organizations have slightly different recommendations. So as a gynecologist, I usually go with the American College of Obstetrics and Gynecology, which recommends mammos starting at age 40 and then continuing every 1 to 2 years, depending on a risk assessment, through the age of 75. So October is Breast Cancer Awareness Month. I hope all of you are empowered to speak to your provider about your personalized breast cancer screening strategy. And then finally, nearing the end of the presentation, I just want to briefly discuss one of the newest forms of cancer screening, which is screening for what's called hereditary cancer syndromes. So hereditary cancer syndromes are defined as a genetic predisposition to certain types of cancer, often with an early age at onset. And so they manifest in families as a strong history of a certain type of cancer or a certain group of cancers. There are several companies nowadays which offer multi-gene screening panels for these conditions. And as gynecologists, we've been early adopters of this technology, as many hereditary cancer syndromes include breast and gynecologic cancers. So these are the things that are affecting our patients. Some of the most prominent examples are BRCA, or sometimes called BRCA, or Lynch syndrome, which is associated with uterine and colon cancer, BRCA being breast and ovary cancer. So we are offering this testing in our cottage clinic through a company that's called Myriad Genetics. And what I love about it is that they've just really simplified the screening process. So interested patients are able to scan a QR code with their phone, which we often give at the annual exam, and it can be done in the waiting room, or it can sometimes even be done in the exam room while you're waiting for the provider. And this will direct the patient to a questionnaire about their personal and family history of cancer. It takes about 5 minutes to complete, so pretty quick. And then immediately after submitting, one will get a response if they meet National Comprehensive Cancer Society guidelines for testing. If they meet criteria for testing, patients are encouraged to discuss with their provider if they want to go through with that testing. So it's pretty easy to do the test. It's done through a saliva sample, and it's often covered by insurance, but people should really be informed about the implications, the results, because a positive result can be a big diagnosis for people and have implications for their children. But for people who want to know, it's an amazing test. And this type of genetic testing is really the future of what is being called precision medicine. Precision medicine is the newest technology in which molecular information is being used to tailor healthcare, really with the goal of preventing or modifying the risk for disease. This is very exciting. I'm super interested and exploring it, still learning more about it, but we're excited to be offering it at our cottage clinic and providing this to women in our community. So this is just a very detailed slide, a very confusing slide, but it talks about this Myriad MyRisk hereditary test. Basically, it's a 48 gene panel that tests for genes associated with 11 different types of cancer. So breast, ovary, uterus, prostate, pancreatic, and many others. So if you're interested, I encourage you to reach out to our clinic. This concludes my presentation. Thank you very, very much for being a kind virtual audience. I hope I've motivated you to schedule an appointment with your gynecologist. Thank you very much, and I'll transfer back to Christy Borman.
Thank you so much, Dr. Gray. That was so informative and so interesting. So we really appreciate it. So we're going to move now to the question and answer portion of our session. And I do want to remind everybody that this is being recorded and will be sent out in the coming days. So I'm going to read off some questions that we have. The first question is there any treatment for HPV infection?
Is an excellent question, and the answer to that is no. So there's not a medication that we can give or an antiviral that can make HPV go away. So no, the way to treat it is to identify it if it's identified, to offer appropriate testing, and then also to prevent it through vaccination.
Do you treat hormone replacement therapy in your practice? And if so, can you speak about it?
Yes, we definitely do menopausal hormone therapy in our clinic. In fact, all of our providers in this clinic are certified by the North American Menopause Society. So we're practicing according to kind of like the most up-to-date guidelines. But yes, we definitely do it. I'm not going to go into the discussion of that because that is a whole nother presentation. And in fact, I think my colleague, Dr. Lisa Lapine, actually gave one of these with the doctors on that. But yes, please schedule an appointment. We have spots available for hormone consultations.
Great, thank you. Are there any side effects to the vaccine, the HPV vaccine?
Yeah, so another great question. So it's a very safe vaccine, meaning there's no major side effects or many big long-term safety concerns. The most common side effects is muscle soreness, so it's an intramuscular injection, so that's the most common. And then the other reported side effect is like syncope, which is the medical word for fainting, is common after that. So oftentimes we will observe people for 15 minutes. But it's often related to just anxiety about needles and shots, probably not anything specific in the vaccine.
What age groups qualify to complete the hereditary cancer screening? And is it only for females or males as well?
It's for all people, definitely, males and females, and there's no real age limits. That's a great question. I mean, but I think being an adult, being 18 years old, I wouldn't offer it to a minor because obviously you would need to make decisions about your health if you were to have a positive result. So in my practice, I would offer it to adults only. Um, but yeah, it could be for both genders for sure.
And is it typically covered by insurance?
Yes. Myriad says that over 90% of people can be covered through insurance. Some special insurances will require prior auth or a prior authorization, or sometimes they'll make a person meet with a genetic counselor. They won't just accept the counseling that's given by a provider. So in our clinic, we've started offering the testing in August. So I can say I only have a couple of months of data, but I haven't had many denials. I usually can get it approved, and I haven't had many people have to do much extra meetings. The other really great thing and part of why our clinic chose to work with Myriad is that they also have established kind of a cap on the cost for people who choose not to go through their insurance. And so we feel like the test is actually pretty economic for people, even if your insurance declines it altogether. A test can usually be done below $300 out of pocket cost.
Are there any specific recommendations for women over 80 years old?
Is this referring to mammogram?
It doesn't specify. So just anything in particular that might be different for somebody, whether it be mammogram.
So for mammograms, different organizations have different recommendations, like I alluded to. But in general, the idea is that breast cancer screening should stop at an age in which either people would choose not to be treated, and I don't think that that's 80 years old. But everyone, it's a very soft call on when to stop um, mammograms. So if somebody is a very healthy 80-year-old and has many years of a long, healthy life left, they may choose to pursue mammogram, and I think that would be totally reasonable.
For somebody already infected with HPV, would you recommend, I think you answered it, and I think the answer is yes, but can you clarify and confirm that you would still recommend that they get the HPV vaccine?
I do, yes. So we like to speak in terms of science and in terms of the data that we have. So there is this idea that probably receiving the HPV vaccine helps you hide the infection that you've already seen. And this comes from that data that shows that in women who are treated for cervical precancer, the women who received the HPV vaccine had a less chance of recurrence. So something about receiving the vaccine was protective, and it's probably because it's helping your immune system hide it. What we know is that your highest risk of developing precancer or cancer of the cervix is persistent HPV infection. So we really want to get your immune system to get rid of it on its own, and then we can kind of break what I call the vicious cycle of abnormal pap test.
And I take it that applies for males as well. That was a question.
Yeah, yeah. So vaccination of males is just so important. So oftentimes the conversation that I'm having in my clinic is um, somebody comes back and tests positive for HPV infection, and then they ask me like, what should I tell my male partner, right? Because people want to be honest, people want to be forthcoming about their partner. And what I usually tell people is, well, first off and foremost, we're not exactly sure how long that infection's been there or who gave it to you, right? We know it's a sexually transmitted infection, so it was transmitted through a sexual partner, but which partner we're not sure. And then if you've been having sexual activity with that partner, most likely you've already shared the same HPV strains, and we don't have to worry about the risk of like reinfection. So people ask like, okay, if I clear my infection because the data is pretty good that I will, and then I engage in sex with that partner, will I become reinfected? And the answer to that is no. HPV doesn't really work like that. Most of the times, once you hide the virus, it's hidden. But sometimes, if your immune system takes a hit, that same infection can reactivate. So a lot of viruses are like that, and HPV is like that too. So people ask me like, what should I do to tell my sexual partner, or should I tell them? And I normally say yes, that we should talk with our partners about that. But in general, for men, HPV infection causes a lot fewer issues than HPV infection in women. It can cause genital warts in men. It can cause cancer of the penis. But the best way I explain it is that in males, the genitalia is on the outside of their body. So if there's something that comes up or something that looks abnormal, a lesion, they're seeing that pretty quickly. The whole issue with HPV infection and its associations with cervix cancer is that the cervix is an organ that women are not able to see on their own most of the time. So it's at the very top of the vagina, and usually it's pretty hard to see, except by a provider with that speculum exam. And so people are not, in early stages of HPV infection or cervical precancer is asymptomatic. So you won't know anything about it, nothing abnormal. It's not till really advanced stages of cervical cancer will there start to be symptoms. And so that's really where the pap test came in and was a form of cervical cancer prevention. But yeah, I think telling your male partner is important. And then and reassuring them that there's no way to test for HPV in men, but most likely they have it, and they just need to kind of watch out and do their self exams. And then vaccinating men, I think, is really the future. So men and boys, right? Because ideally, the ideal time to vaccinate is before the initiation of sexual activity. That's why current guidelines are recommending to start as early as 9, ideally around age 11. And so pediatricians are really doing the bulk of the work for HPV vaccine. I would say as gynecologists, we're kind of doing catch up for the women who maybe missed it. And then also this new cohort of patients who have become available since the FDA has now allowed it through age 45. So I'm usually playing catch up, but really the ideal time is young. So if you have children or grandchildren, I'm always encouraging you to talk about with their pediatricians about that, because that is the best time, the prime time.
So for some of the later stages of cervical cancer, what would some of those symptoms? We understand it's asymptomatic in the beginning, but what are some symptoms to look for if it maybe is already further down the road?
So, well, cervical cancer, so abnormal malodorous vaginal discharge, bleeding, so irregular vaginal bleeding, because oftentimes cervical cancers are like necrotic masses on the cervix, and so there's irregular bleeding between periods, and then also bleeding with sex is a big one that we look out for. But the real truth of the matter is that cervical cancer is much less common. And it's usually seen in women who have been out of care for more than 2 years. I'm sorry, more than 10 years. I apologize. So when we look at studies of women who develop cervix cancer, they usually have not had a pelvic exam or a pap smear in the prior 10 years. It speaks to a topic that I didn't really go into in the presentation, but is really, really interesting. And that's the timing of acquiring HPV infection to developing a cervical cancer is very, very slow. So this is why it's so easy to prevent cervical cancer. We have a lot of time to catch it. On average, it would take at least 15 years from time of acquiring HPV infection to developing a cervical cancer. Well, it's a very long time. It's quicker in women who are immunocompromised. So if somebody has, is taking an immunosuppressive drug, either for an autoimmune condition, or they've had a transplant of some sort, or they have an infection like HIV that lowers their immune system, that's when we can see that things can happen a little bit more quickly. But in healthy, immunocompetent women, it's a very slow process, and there's plenty of time to act.
Great,
I
thank you.
did my training, I think I mentioned I did my training in Miami. So I actually have seen a lot of cervical cancer, and it was most common in women who've been out of care, either because they've recently immigrated here or from countries that didn't have good medical care, or people with complex social histories like homelessness or drug abuse, those type of things. But that is kind of who we see the most cases of cervical cancer in nowadays.
Thank you. Can you speak to uterine fibroids and or ovarian cysts? Do you recommend the removal of them even if benign?
Mm, um, I would, if you have either of those conditions, I think I'm definitely seeing a gynecologist regularly, but no, I don't routinely recommend against the removal of uterine fibroids if they're completely asymptomatic, because they're very common. 80% of people who arrive to the age of menopause will have a fibroid. And they're almost always benign. So they don't convert to cancer, or they don't turn into cancer, anything like that. So unless they're causing problems, we don't normally intervene on them. And then ovarian cysts, that's a little bit different of a discussion. So it kind of has to do with their appearance on ultrasound. There's simple cysts, then there's more complex ones. And based on their appearance, we have different levels of concern for something like ovarian precancer or cancer. And so that can guide the decision of observation versus surgical removal. But it's a pretty complex discussion. So something that you'd really want to talk with a gynecologist about.
How frequently should someone get a fibroid checked?
Oh, excellent question. So I don't recommend routine surveillance of fibroids. So it's not like, oh, I know I have a fibroid, and so every X number of months I need to get an ultrasound. No, we don't normally recommend that. We still would do a pelvic exam and just make sure that there's no signs that it's growing, because that can usually be felt on physical exam. Or what I always tell people is if like there's a change in their bleeding pattern. So again, the menstrual cycle is a vital sign. So we extract so much information. If you were previously having regular periods and then suddenly now you're very irregular, or if you're previously having a normal quantity of flow and then now you're excessively bleeding, that would prompt an investigation. So we should guide it based on kind of your clinical symptoms.
Can you clarify your recommendation for a pap test for women over 80?
Over 80?
Yes.
So, and women over 65, the recommendation is to discontinue pap smears. There's a lot of ifs and criteria that are supposed to be met, but that's if you've had regular and consistent screening throughout your life, and you don't have a history of advanced cervical precancer. So if you have mostly normal pap smears throughout your life, and the two most recent ones have been negative, and within the last 10 years, you can discontinue at 65.
If a male or female has HPV but no warts, are they still contagious during sexual activity?
Yes. Yes. So warts are only some types of HPV infections. So the strains that are associated with warts are not the strains that are associated with abnormal pap smears and precancer. So that's a really important point of clarification. And genital warts are not precancerous. People don't like them; they're transmittable and pesky, but they are not precancerous. Yeah.
What would a breast cancer screening recommendation be for families with first degree relatives with pancreatic cancer deaths?
So I need to know a little bit more information, but particularly if there was also a family history of breast cancer, that would raise suspicion for BRCA, or that hereditary cancer syndrome does have a pancreas association. But I think if it's just pancreas, I'm not sure if you'd meet criteria. Now, I say I'm not sure. I really truly do depend a lot on that QR code, because the guidelines on who meet criteria for screening are so challenging. It's not something that I could commit to memory. So you have to have like the right combination of different things to meet criteria. But if you have that family history, and that's your question, I would really encourage you to schedule an appointment at our clinic, and you can even just drop in and do the QR code. I think we're in the process of trying to post our QR code to our website so that people can do it that way too. And then if you're a male, it's also something that can be discussed with your primary doctor, because you can also be referred to speak to a medical geneticist. And so we have those opportunities in our community as well, and they can order the appropriate screening panel.
Should someone get a pap test if they are not sexually active?
Oh, I'm so glad this question was asked. So current guidelines say that yes, we should do pap smears even if you have never been sexually active. And the reason for that is that most cases of abnormal paps are HPV related, but not all. So I think like 90% are, but not all. So that's why that guideline exists. Um, that being said, in my personal practice, I often, it's a shared decision between the patient and I, because I understand that people who have never been sexually active may not want a pelvic exam. That may feel intrusive in some way, or be very uncomfortable. And I'm certainly sensitive to that. And I normally reassure patients that, like, if the timing is not right for you right now, I don't think you're being negligent on your health. It's pretty low risk to have an abnormal pap, so it can be safely deferred until you feel more comfortable with it. And this is for people who have never had sex, right? So then there are people who are like, well, just right now, I'm not sexually active. And then I would really encourage you to get routine pap smears, because it's not just about your sexual activity at this time, but you may have been exposed through prior sexual activity. And so you should be on that routine screening regimen.
We're asking for questions about the QR code. If someone's not a Cottage Health patient, how can they find that QR code or get access to it? I know we're going to be sending some information out after this, but do you have any
Yeah,
other thoughts on
so
that?
that QR code is generated specifically for our clinic. So you would need to be a cottage clinic, and the company develops a QR code for each specific organization that's offering the testing. But if you're not a patient, and for whatever reason you don't anticipate scheduling an appointment anytime soon, again, this testing is not just something that we're offering here. It can be done in other medical centers. You can talk to your provider, even a primary doctor. Prior to us offering it in our clinic, what we were doing is referring people to medical geneticists. So that is something that can be done if an organization is not working with a specific company.
So I know we have a lot of very specific questions, which I appreciate. I'm just looking at them all. So I would just encourage folks, if you have specific questions, to make an appointment with Dr. Gray. We'll be sending a link out after this with the recording. Dr. Gray, did you have anything else you wanted to add?
No, I don't think so. Thank you for the opportunity.
Thank you so much. Cottage OB-GYN Clinic is located at 2416 Castillo Street, Unit A in Santa Barbara. So as I've mentioned, immediately following this presentation, you'll receive a link to request more information or to make an appointment with Dr. Gray. We will also email a recording of this presentation in the coming days. If you have further questions or would like more information, you can always call 805-324-9400 or visit the URL. And a brief survey will appear after this webinar. So we'd love to hear your thoughts. And with that, again, the recording will be available in the next coming days. So keep an eye out for that in your email. Thank you again for joining and have a happy and healthy rest of your day.